Welcome to AETCM, the emergency medicine channel.
Yes.
Presenting the case of a 21-year-old female who presented to ER with complaints of right lower abdominal pain since the last 2 days and 2 episodes of vomiting half an hour before arrival. On initial 10-second assessment, the patient was conscious and is talking in full complete sentences. The airway was patent, there was no pooling of secretions or gurgling sounds or stridor. Breathing, the respiratory rate was 18 per minute, saturation of 96% in room air. The air entry was bilaterally equal and the chest was clear. And on circulation, BP was 110/70 millimeters of mercury with a heart rate of 73 per minute and saturation of 99% in room air, capillary refill time of 2 seconds. And disability, the GCS was E4, E5, M6 and GRBS of 100 milligram per deciliter. And exposure, the temperature was febrile and there was no presence of any rashes. The pain score was 5 out of 10. And so initially we had given an injection paracetamol, 1 gram IV stat we had given. And
What type of pain it was?
It was kind of a colicky type of pain.
What is the use of paracetamol in such colicky pains?
Yes.
What is your opinion regarding paracetamol in colicky pain? You are only giving, I am asking. Will it work? Yes or no? It will not work. Spasmodic pain, paracetamol will not work at all. You have to give something along with paracetamol. Spasm may be due to some inflammation. The inflammation will come down, but spasm will never come down with paracetamol. That's why we have combination of paracetamol with dicyclamine, mefenamic acid with dicyclamine. So many combinations are there.
So initially, the pain score did not improve. Then we give dicyclamine.
Any colicky pain, if you are giving paracetamol, it's okay. It's accepted that there may be some inflammation. But you have to always give a dicyclamine along with paracetamol or whatever NSAID you give. Otherwise, pain will not subside.
Yes. So as adjuncts to primary survey, we took a CBC-CRP with a total count of 6,000 with a CRP of 5, CRP of 5, and VBG showing just normal. There was a creat was 0.62. And then we reassessed the pain score. The pain score, it was still persisting 5 out of 10, so we gave dicyclamine, and following which the pain score reduced to 1 out of 10. We took the amble history, sir. Amble history, the patient is a 21-year-old female with a previous history of torsion left ovary, and for which oophorectomy was done for that patient, which was done 2 years back, and came with complaints of right lower abdominal pain, which was radiating to the back. Along with it was a colicky kind of pain, and there was also associated with 2 episodes of vomiting. These vomiters contained food particles. It was not triggered by food intake, and there was no. It was non-projectile, non-bilious, and not blood-stained. And there was no history of any fever, headache, or any loose stools or constipation associated. And there was no history of any increased frequency of micturition or reduced urine output, or there was no history of any hematuria or dysuria, and there was no history of any trauma to the abdomen. And medication history.
Menstrual history.
Yes, menstrual history. Last menstrual period was on April 20th.
How many days?
It was around 10 days back.
10 days.
Yes. And medication history, no significant medication history. Sir. No, he's not using any medication.
What is the importance of menstrual history in this patient?
There's a possibility of an ectopic pregnancy.
So every patient comes with colicky pain, you are suspecting ectopic pain.
It's an emergency.
It's okay. What is a common reason for abdominal pain in female patient?
Ovulation.
There will be pain.
Menstrual cycle.
Yes.
So that is very important. Whether the patient is having menstrual cycle, near menstrual cycle, or immediately after menstrual cycle, many patients can have abdominal pain. Like you told, pregnancy is another important thing. Yes. There also you can get all these things.
Or sometimes patient can have mid-ovulatory
Mid-ovulatory pain.
also.
Okay.
And so the past history, the patient had a history of left ovarian torsion, which occurred 2 years back, and for which left oophorectomy was done for this patient. No
That
other.
time, what was the reason for torsion? Is it
There was
inflammation?
presence of a left ovarian cyst.
Any
Sir.
cyst,
Cyst
okay.
was present, sir, of a size of
What
around.
is the common cause for ovarian torsion?
Ovarian torsion, there's presence of ovarian cyst.
Cyst is the most common cause.
Yes, sir. And so along with then we moved on to the general exam. The allergic history, there was no any allergic histories. And the general examination, there was no history of any, no presence of any pallor, icterus, cyanosis, clubbing.
What does pallor mean in this type of patients?
So pallor means that there could be presence of increased blood loss or anemia, or if patient is having a menstrual bleeding.
You're in an emergency room.
Yes.
Patient come with right-sided severe colic abdominal pain, young female. If pallor is there, what is the first suspicion? Hemorrhage due to
ectopic pregnancy.
pregnancy. So there you have to suspect ectopic pregnancy with bleed.
Yes. Okay. And there was no clubbing or there was no presence of any pedal anemia. And on systemic examination per abdomen, there was tenderness present in the region of the right iliac fossa, and there was presence of bowel sounds were present, and there was no presence of any external discoloration. The previous surgical
External discoloration means?
So if there's presence of any hemoperitoneum, there can be the presence of discoloration like Cullen sign or Gray Turner sign can be present in the abdomen. And there was no presence of any external swelling. And there was presence of previous surgical scar in the left, and the chest, it was clear. There was no presence of any added sounds, and the normal vesicular breath sounds were present. CVS S1 S2 was normal, and CNS there was no presence of any focal neurological deficits. And in this patient, we took as an emergency, we took a USG abdomen with an USG ovarian Doppler for this patient. And for this patient, it was shown that the right ovary was bulky and edematous, so showing a cyst of about size of 5.4 into 4.1 centimeter, with sparse parenchymal vascularity. And there was a presence of a presence of heteroechoic area also, of measuring 3.6 centimeter and 3.4 centimeter, like query of a hemorrhagic cyst with a torsion was what the diagnosis had come. And in this patient, initially itself, we kept the patient as NPO, and then we had.
So what are the blood? So ultrasound Doppler is the most important thing.
Yes, sir.
What are other blood investigation you do in a suspected torsion or right iliac pain?
Right iliac pain, we must always look the complete blood count. Complete blood count, if patient is there can be the presence of leukocytosis. Or if raised CRP is present with leukocytosis, there can be the possibility of an appendicitis, DD of
one of the
differential diagnosis of ovarian torsion. If patient is having pain in the right iliac fossa. And then there is also there can be presence of, we should check for RFT. If patient is having any deranged RFT, there can be the presence of a hydrourethronephrosis or renal calculi or URE showing numerous pus cells or presence of RBCs. That can be the possibility. Then
other tests immediately you can do in emergency room itself, point of care. Beta HCG?
Beta HCG can do.
All patients who is coming with this type of pain, you must do it. Because Doppler, ultrasound, all will take time. Okay, the other one can be done immediately, in ER itself.
Yes.
Then
so these are the basic.
Okay. Then what happened to the patient?
So this patient, then we had immediately called for the gynecology department for an urgent intervention. They had admitted the patient, and initially they had observed the patient, and the observation, the pain had reduced. They did a repeat ultrasound, and which showed that the patient had a manual detorsion with the reduced, the vascularity had improved. So they kept her on conservative treatment because of she already had a history of left ovarian torsion and oophorectomy. So they managed her conservatively. So we move to ovarian torsion. So ovarian torsion is actually a complete or partial rotation of the ovary on its ligamentous support. So it's leading to a partial or complete obstruction of the blood flow. So that blood supply.
What are the blood supplies of ovary?
Blood supply is mainly supplied by the ovarian vessels, and also there is a supply by the uterine artery.
So it has got dual supply.
Dual blood supplies, and mainly these symptoms can be present. This condition can be present in females of any ages. Even in fetus, the patient can present with ovarian torsion.
Okay, which age group it is common?
Common in the case of adolescents.
Which age group it is more painful?
But it's mainly in older, like 40s.
Whatever case you have seen, all are younger
Age, yes.
And old age, it's less painful. Okay. There the reasons are different.
Yes. Okay. So usually, sir,
what are the other reasons for ovarian torsion? Other than cyst is the most common thing. What we see in our practice is cyst only.
Yes. The presence of even ectopic pregnancy.
Ectopic pregnancy
can lead to ovarian torsion, and there can be
elderly individual. What are the common reasons?
Tumors,
including benign or malignant tumors.
Yes.
So that is not that painful like younger individuals.
So numerous variables affect the flow of the uterine arteries. Okay. Mainly the number of twists in the blood vessels, and also the tightness of the twist is what is mainly dependent. And usually the complications associated ovarian torsion presents with the features of mainly pelvic pain, which is usually a sudden onset pelvic pain.
With the bilateral pelvic pain, what is your diagnosis? Say unilateral
pelvic pain. It's always
bilateral pelvic pain. What will you suspect? Young female coming with bilateral pelvic pain. UTI is a common thing that we see in our practice. That is correct. Urinary tract infection. PID is one of the common reasons for bilateral pelvic pain in a sexually active female patient.
Yes.
So we should not miss that.
Okay. Yes. So usually the pain character, its severity would be moderate to severe, the intensity of pain. Along with the character could be sharp pain or a dull or a kind of colicky pain or a crampy pain is usually present, which radiates to the flank, the back or the groin. And usually most patients come usually within 1 to 3 days of the onset of pain due to its increasing severity. And the patient would if we are having a patient with this pain with abdomen distension, we must suspect an ovarian mass, which could be the reason of the torsion. And patients could be present with nausea or vomiting also. And a patient can also be present with complaints of fever. If presence of fever is there, it could be a marker of an adnexal necrosis underlying of the ovary involved. And in physical examination, usually there will be presence of a pelvic or abdominal tenderness, along with there will be and signs of peritonitis can also be raised. There is a possibility.
What are the signs of peritonitis?
There will be a presence of rigid abdomen.
Board-like
rigidity of the abdomen.
Throughout the abdomen.
Yes.
Okay. Any rupture, adhesions, all these things can produce peritonitis.
Yes. So usually in the case of ovarian torsion in USG, when we take an investigation, before the risk factors, usually risk factors of ovarian torsion is in the case of a patient is having an ovarian mass, a mobile ovarian mass, or a history of a prior ovarian torsion, and if that person had a detorsion, there is always a history of recurrence of ovarian torsion, and also history of tubal ligations in pregnancy or post-pregnancy, and the history of a pregnancy, and along with PCOS, and also ovulation induction, if any agents are given, that can increase the number of follicles and increase the size of the ovary, leading to an ovarian torsion. And if the ovarian mass, if the size is more than 5 centimeter diameter, there is an increased risk of ovarian torsion. And even in endometrioma or even tubo-ovarian abscess can also present with lead to ovarian torsion. And So in USG, usually, sir, the ovary would be round, enlarged, and there will be a presence of heterogeneous. If there's presence of any heterogeneous appearance, it indicates a hemorrhage, and it usually could indicate an edema or a hemorrhage. And along with that, there's a presence of multiple small follicles, and if along with that, there will be presence of the ovary. The presence of the ovary will be anterior to the ureter in case of torsion. If usually the ovary lies posterior to the ureter. In case of torsion, the ovary lies anterior to the ureter. And the ovarian vessels, they'll show the presence of a whirlpool site. That's called as, it is the hyperconcentric. There will be presence of heterogeneous echoes, which is seen in the Doppler. So that is due to the twisting of the vascular pedicle. So it will be forming like a whirlpool. So that's why it's called as a whirlpool site. And the differential diagnosis of ovarian torsion usually involves a ectopic pregnancy. So that's the initial thing what we have to rule out. Patient will be having an adnexal pain with an adnexal mass, and we initially should take a beta SCG to rule out presence of pregnancy, and a rupture of an ovarian cyst. So that can also be present. But usually that pain will be present mid-cycle of the menstrual period. And tuber ovarian abscess. Tuber ovarian abscess will be having a presence of high-grade fever compared to the presence of in ovarian torsion. Fever will be low-grade with necrosis. But if patient is having a tuber ovarian abscess, it will be high-grade fever. Along with that, if patient, and in ultrasound there will be presence of multilocular mass. So that's the difference. And appendicitis, patient will be having anorexia, vomiting, along with that periumbilical pain. So initially it will start as a periumbilical pain, then moving on to pain in the right iliac fossa. Okay. And CD64 is a marker which can be used to differentiate between appendicitis and ovarian torsion.
Okay.
So usually the definitive diagnosis of ovarian torsion is usually intraoperative.
Okay.
Is what is told.
MRI, CT, anything is required?
If it's diagnosed by USG with the Doppler,
Doppler alone is enough to make a diagnosis. MRI, CT all required in which conditions?
It's the presence of an ovarian mass.
Mass. If you have a mass only, you need to go for all these things. Yes. Otherwise, a Doppler alone is enough.
Yes.
What happened to the patient?
Yes, sir. This patient, he was they did a repeat USG, which showed detorsion, and the vascularity had improved. So that's why they managed conservatively. And
so next time when you get a colicky pain, what will you give? Paracetamol.
Dicyclomine.
Dicyclomine is first line. I don't know why you are still using paracetamol. It is not going to help at all, because there is no actual inflammation here. Torsion produces, or most of these conditions produces spasm of the muscles, not inflammation. Inflammation may lead to spasm in some conditions.
Yes, sir. Then basically about management also.
Okay.
So if patient is having a torsion, if patient is premenopausal, we must check the viability of the ovary.
Okay.
If patient is not premenopausal, we can move on to salpingo-oophorectomy.
Okay.
If patient is premenopausal, we must check the viability. If viability is not present, we must go for salpingo-oophorectomy. If viability is present, we must look whether there is any concern for malignancy in that individual. Okay. If there is concern or any presence of any malignant markers present, we can go for salpingo-oophorectomy. If there is no signs, we should check about the is there any benign mass. If there is presence of a benign mass, we must go for a possible cystectomy, considering the fertility status of the individual. The patient is any child is only there for the individual. Okay. The parity of the individual is what is the criteria. If a patient does not have any benign mass and only signs of torsion with there is a need for a childbearing, we can go for a manual detorsion. So that's how that management goes.
Anything else you want to add? Nothing.